A patient of 67 years comes obtuse into the ED. The medical history presents with hypertension, cough in the last 2 weeks, and feeling of weakness. On the physical exam, he has a dull area of percussion in the lower right thorax with egophony. Temperature is 39 degrees Celsius. The respiratory rate is 27 per minute. The systolic blood pressure is of 85 millimeters Hg. His labs show a BUN of 50. The chest radiography shows a lobar consolidation. It is decided that the patient is intubated and put on antibiotics. Despite improvement in the last 2 weeks, during the first week another area of dullness is observed on the left. What is the best treatment now? Ceftriaxone plus azithromycin, amoxicillin plus sulbactam, levofloxacin plus cefepime, or doxycycline. The clinical presentation in the beginning is a community-associated pneumonia, but he is treated in the first phase, so it's a hospital-associated pneumonia. Why he was hospitalized? Has actually a 5 out of 5. He is confused. He has uremia of 50 milligrams per deciliter. He has a respiratory rate greater than 20, a systolic blood pressure that is lower than 90, and he also is actually 67 years. The answer is C. The patient developed a secondary pneumonia classified as ventilation-acquired pneumonia. Therefore, the treatment must include a large spectrum cephalosporin that covers Pseudomonas aeruginosa. This is represented in the answer by cefepime. Until a blood culture is obtained, we either used aminoglycosides or quinolones additively to cover the antibiotic-resistant Pseudomonas strains. CURB65 is an index that we use to establish if we hospitalize a patient or not. The patient's score is of 5 out of 5. This is an indication for intubation, not only hospitalization. Scores of 2 to 3 indicate hospitalization. Scores of 4 to 5 indicate ICU admission. CURB65 is 1 point for each criteria. C comes from confusion, U from uremia, R from respiratory rate of greater than 20 per minute, B from systolic blood pressure of less than 90, and an age of more than 65 years. Let's recap a little bit what antibiotics do we give in pneumonia. So if we have an outpatient with community-acquired pneumonia that has less than 65 years and he had not received any antimicrobials in the last 3 months, we either use macrolides or fluoroquinolones. If we have an outpatient with community-acquired pneumonia of greater than 65 years with antimicrobials in the last 3 months or comorbidities, diabetes, COPD, we opt for a third-generation cephalosporin, fluoroquinolone, and a macrolide. A community-acquired pneumonia requiring hospitalization goes with fluoroquinolones or antipneumococcus beta-lactam plus a macrolide. Pneumonia acquired at more than 48 hours from hospitalization or after intubation is treated with antipseudomonal cephalosporin plus aminoglycosides or quinolones until results of bacterial sensibility. If we suspect a MRSA in a critically ill patient, we administer vancomycin or linezolide. We suspect MRSA in the case of patients that, for example, are in hospital inpatient unit and they were treated with an antipseudomonal and their state is still severely ill. Another clue for MRSA is the fact that we have abscesses associated with them, pulmonary abscesses.